Okay, next we're going to talk about statins. And we're going to start with statins and this fascinating nocebo effect. A couple of recent relevant studies published in the New England Journal of Medicine and also the BMJ. Now we know, don't we, from our collective clinical experience that statins are often stopped due to side effects. Everyone we start a statin on knows someone who's had muscle pains or other side effects with statins. And this actually neatly summarizes the nocebo effect. So what is the nocebo effect? The nocebo effect is the opposite of the placebo effect. So a negative outcome occurs due to a belief that the intervention will cause harm. Everyone, as I said, knows someone who's had side effects with a statin. So these negative preconceptions increase the number of adverse effects and symptoms experienced by humans. So personal or others' experiences, views, knowledge of others, social media, the lay press all drive negative expectations, which are partly unconscious, which lead to adverse effects and symptoms. So this has led to a number of what we call N=1 clinical trials, single subject clinical trials to investigate the efficacy or side effect profiles of different interventions, including statins. So the first of these was published during 2020 in the New England Journal of Medicine, an N=1 trial of a statin of placebo of no treatment to assess side effects. 60 individuals recruited who had previously been intolerant of statins within 2 weeks of starting them because of side effects. This was a double-blind trial, so participants, investigations did not know what treatment individuals were receiving, and it was designed to test whether symptoms would be induced by statin or by a placebo. So individual participants received 4 bottles containing atorvastatin 20 milligrams, a standard primary prevention dose of atorvastatin, 4 bottles of placebo tablets, and 4 empty bottles. And each bottle was used for 1 month according to a random sequence. And patients used their smartphone app or other device to report symptom intensity daily, okay? Symptom scores range from 0 all the way up to 100. And if symptoms were unacceptably severe, patients could discontinue their tablets for that month. And interestingly, symptoms were so bad that people had to stop taking the tablet on 71 occasions, including 31 times while they were just taking the placebo tablet during the course of the study. So really interesting finding there. So what were the mean symptom intensities? So the mean symptom intensity was 8 during the no tablet months, 15.4 during the placebo months, and 16.3 during the statin months. So that means in patients who had discontinued statin therapy because of their side effects, 90% of the symptom burden elicited by the statin challenge was also elicited by the placebo drug. So very interesting finding there, and really reinforces what we knew already in primary care. Those negative expectations often drive side effects of statins. But reassuringly, half of the trial patients were able to successfully restart statins. So well worth us being aware of this in primary care and counselling patients appropriately, explicitly discussing the nocebo effect and asking patients to persevere or retrial statins. And similarly, the statin-wise trial published during 2021 in the BMJ found no significant difference between atorvastatin 20 milligrams and placebo drugs in people who had previously reported severe muscle symptoms when taking statins. So the exact reason why statins produce a nocebo effect remains unknown, of course, but the suspicion is they have achieved a self-fulfilling destiny, with media reports, with us as GPs, nurses and pharmacists and our cardiology colleagues warning of the side effects of statins. So some food for thought for us all in primary care, and some bodies are suggesting the use of these N=N=1 trial packs in everyday clinical care to try and improve concordance, compliance, adherence with statin therapy. And next, I'll quickly discuss, are we ever too old for a statin? This was an interesting paper published in the Lancet during 2020. Large primary prevention cohort study, over 90,000 individuals, exploring the association between LDL cholesterol and the risk of subsequent myocardial infarction or other atherosclerotic cardiovascular disease, but importantly in individuals aged 70 to 100. Now, previous studies have suggested that an elevated LDL cholesterol levels were not associated with an increased risk of myocardial infarction in individuals older than 70. But this idea was probably based on the misconception of survival of the fittest, and that people who have not had a vascular event before the age of 70 were healthier and had a subsequently reduced risk of atherosclerotic cardiovascular disease. So that's why this study was very helpful to either verify or refute this hypothesis. So what did this cohort study find? Well, they actually found the number needed to treat over 5 years to prevent one atherosclerotic cardiovascular disease event using a moderate intensity statin therapy, atorvastatin 20 for example, was 164 in those aged 60 to 69, 88 in those aged 70 to 79, and just 42 in those aged 80 to 100. So this study very much, and the conclusions from the study very much support the idea of the cumulative burden of LDL cholesterol over a person's lifetime, and that progressive increase in the risk of myocardial infarction and other atherosclerotic cardiovascular disease with age. So, this previous idea that high LDL cholesterol in apparently healthy people over 70 is benign is not true. We have demonstrated now this high LDL cholesterol in these older groups are indeed associated with a higher risk of myocardial infarction and atherosclerotic cardiovascular disease.